So so we can start the presentation. And if you look at the overall picture of obstetrics section, I think 30 to 40% of questions were really the ones which were easily solvable, but for majority of the questions there was application of knowledge was needed. Like, you should have a theoretical good knowledge about that topic, and you should be able to apply that knowledge onto the question as well. So overall obstetric was, I can say, 40% scoring only, not that good as such. Anyway, going forward and taking one question, and here we were having a question about calculation of Bishop's score. Now this is for the very first time we have a question something like this, because till now it was all about like all of the following are parameters of Bishop's score, or what is the what we want to do by calculating Bishop's score. So usually this question was of that kind, but this time they gave you some findings and it was up to you to calculate the Bishop's score. Now if somebody know the exact table of Bishop scoring, then it was pretty easy, but otherwise it was little difficult question, I would say. So starting with the question, and here one of the parameter, that is like effacement, was given as 20%. So if we look at the effacement column, the 20% value will be awarded a score of 0. So 0 to 30% effacement will be given a score of 0. Then coming to consistency as soft. So coming to consistency as soft is score of 2. So we will give a score of 2 here. Okay. Then coming to the position. So position is middle. We will give a score of 1. Then station of fetal head is -2 in the question. So station of fetal head -2 will be given a score of 1. And cervical dilatation of 2 centimeter. So dilation of 2 centimeter will be given a score of 1. So to solve such kind of questions, you have to exactly know the entire table of Bishop scoring. Then only it is possible to answer such questions. So overall, if we just add up all these values, the score was 5, which is actually an unfavorable score. Clear? So this is how you need to calculate the Bishop score, and you had to remember 5 points, out of which the 4 points are the maternal cervix, and the 5th point is the fetal head station. Okay, so 4 point relate to mother, 5th point relates to fetal head. So it's like a little difficult because it's not that easy to remember the entire table. So anyway, this was a score of 5, and score of 5 suggests that labor will not begin without any induction. So unfavorable score. Now next question was from a very important topic, that is ectopic pregnancy, and here it was like asked like what should be the duration of the measurement of good morning Arpana Patil. So what is the frequency of measurement of beta human chorionic gonadotropin in a case of ectopic pregnancy? Now here we usually measure it at an interval of 48 hours. So the answer to this question is 48 hours. And if we just go back with the concept, like whenever we are suspecting a case of ectopic pregnancy where there is implantation of the fetus outside the uterus, in such cases we have to check the levels of human chorionic gonadotropin every 48 hours, right? And we will see whether the level is increasing or not. Now in a normal pregnancy, we know that the doubling time is 48 hours. So the HCG levels, they double every 48 hours. So this is with respect to the normal pregnancy. HCG levels in normal pregnancy. They will double every 48 hours. But in a case of ectopic pregnancy, where the implantation is outside the uterine cavity, the rise is slower than the expected of that of the normal pregnancy. So here the rise is not as what we see in a normal pregnancy. So the rise will not be like that, or even it might decline. So by checking the beta HCG values, we can differentiate whether it is a normal pregnancy or an ectopic pregnancy, right? So this is how we should check beta HCG values every 48 hours in a suspected case of ectopic pregnancy. If it doubles every 48 hours, we can say it is a normal pregnancy. If it fails to doubles every 48 hours, it is highly suggestive of ectopic pregnancy. Clear? Now then, there was one question about hormone which is responsible for ductal development of breast. So ductal development of breast, this is especially in a non-pregnant lady, this is because of estrogen, right? So in a non-pregnant lady, it is mainly because of estrogen, and in pregnancy, progesterone also has a role to play, right? So in a non-pregnant, it is mainly because of estrogen, which is responsible for the ductal development of breast. Now there was one question about the first maneuver which has to be done in a case of shoulder dystocia. Now, before answering this, you should know what is dystocia. Now, dystocia is like, you can say that there is an arrest of labor because the shoulder, it has impacted behind the pubis symphysis. The shoulder is impacted. So suppose if this is the pubis symphysis, the shoulder is somewhere here, clear, and this is the neck of the baby. So the shoulder is impacted here. So this is the shoulder, and the shoulder is impacted behind the pubis symphysis. And in such a case, unless and until you disengage, good morning Kakul, unless and until you disengage the shoulder from behind the pubis symphysis, there will be no progress in the descent of the fetus, right? So what you need to do here, the shoulder is impacted here, so we need to disengage. So what we'll do, we do a maneuver that is known as Mack-Roberts maneuver. So for shoulder dystocia, we need to do Mack-Roberts maneuver. Clear? So for shoulder dystocia, we need to do a Mack-Roberts maneuver. Okay. Now here what we do, as you can see, the lower limb is, the hip is flexed, the thigh is flexed, the lower limb is abducted, and with one hand there is suprapubic pressure, because if you see, this is pubis symphysis. So the head, the shoulder, it is impacted just above and behind the pubis symphysis. So unless and until you disengage it, there will not be any descent. So we will give a suprapubic pressure, right? So suprapubic pressure, I think all you can understand what is suprapubic. So supra means above, so we have to give a pressure from here, right? Suprapubic pressure with leg in flexion, and this is the Mack-Roberts procedure which has to be done for shoulder dystocia, right? So leg in flexion along with suprapubic pressure, and we know that why we are giving suprapubic pressure, because we have to disengage the shoulder which is impacted behind the pubis symphysis. So this is shoulder dystocia, and please remember Mack-Roberts procedure. Now this is a a basic question. It has been repeated few times as well. Now, this is again one more important question, and it has been it's just a repeated question, if I say. Now what you can see here, the doctor is doing bimanual examination, right? So the doctor is doing bimanual examination. Bi means both, manual means hands. So if you can see, the doctor is using both the hands. This is per abdomen, means from outside the abdomen, and this is per vagina, right? So doctor is using both the hands. One is outside the body, another is inside the genital tract, and he is compressing the isthmus of the uterus. So this area is actually the isthmus. Yes, and this sign is known as Hegar sign. Bimanual compression, right? So this is bimanual compression of the isthmus. Clear? So this is bimanual compression of the isthmus, and this sign is known as Hegar's sign. So this sign has been already asked many number of times. So this is one of the, you can say, repeated questions. So Hegar sign, where there is bimanual compression of the uterus. So upper part of the uterus is enlarged because of the growing fetus, and the lower part is empty. So there is a compression at the site of isthmus. So this is Hegar sign. Clear? And apart from this, there are some other signs of pregnancy which has been asked previously also. One is of course the Chadwick sign, where there is dusky blue or violet hue of the cervix and vagina. So there is bluish or purplish discoloration of the vagina and the cervix. This is Chadwick sign. Then there is one more important sign which has been asked, that is Osiander's sign, and this is actually increased pulsation felt in the lateral fornices. And then there is one Goodell's sign, which is softening of the cervix. And then there is one Piscasex sign, where there is asymmetrical enlargement of the uterus because of lateral implantation. So these are few signs of pregnancy, right? So one should be well versed with them because they had been asked many number of time. So Chadwick sign, Osiander, Goodell's, Piscasex, and the important one, Hegar sign. Clear? So please remember these signs of pregnancy. Now, after a lower segment cesarean section, bleeding is not controlled even after giving oxytocin. So after doing lower segment cesarean section, there is bleeding. The treating doctor gave oxytocin, but despite that the bleeding is continuing. Now what need to be done in such a case? So in such a case we can do two things. Either we can give B-Lynch suture, or what we can do, we can cut the source of blood supply to the bleeding artery. So we can do uterine artery ligation. Clear? So if we ligate the artery, suppose if this is the artery and if it is giving branches like this, and if this is the source of bleeding like this, so if you ligate it from here, there will be no blood flow forward and there will be no bleeding. So this is arterial ligation, and since we are dealing with uterus, so it is uterine artery ligation. So either we can give B-Lynch suture, compression sutures, or we can ligate the feeding artery. Clear? So this is when there is excessive bleeding which is not even controlled by oxytocin. So we have to think of some other method. So here we see this is the B-Lynch suture. Clear? So this can be seen on the anterior posterior aspect, and this is the ligation of the uterine arteries. So if there is uncontrolled bleeding, even after giving oxytocin, we can either give suture or we can ligate the feeding artery, that is uterine artery. Now there is one question which is asked for the very first time, and I think it's a little difficult question, because till now we have this kind of question, but it was mostly diagnosis based. So here a lady who is having a repetitive, you can say recurrent abortion, right? So recurrent abortion, and especially in the mid trimester, this is because of cervical incompetence, right? So this is because of cervical incompetence. It means the cervix is not able to hold the pregnancy, so cervix is incompetent. So this is the usual cause of mid trimester pregnancy loss, cervical incompetence. Now to treat this condition, we need to do cerclage operation, right? We need to do cerclage operation. Now cerclage means like suppose if this is a structure something like this, cerclage means we will tie it all around like this. So cerclage. So here we need to do cerclage operation because we know that cervix will dilate and it will allow the matter of conception to go out or abort. So we can use either a Schrodker's procedure. Clear? So there are two procedures, Schrodker's or McDonald's. Clear? So Schrodker's or McDonald's procedure. The basic difference between the two is in terms of the level of surgery. Now this is slightly higher and this is slightly lower in terms of anatomy, right? So McDonald's and Schrodker's procedure. Now if we look in this image is the Schrodker's procedure, especially the modified Schrodker's procedure. So if we look here, we can understand, see, this is the level of McDonald's, and see the level of Schrodker's cerclage, right? So McDonald's cerclage is towards the lower side and Schrodker is towards the upper side, right? So this is towards the lower side. So these are the two surgeries which are usually done for cervical incompetence, and the principle of the surgery is cerclage. Now the question is about Schrodker here, and even in Schrodker now there is some modification. So the original surgical technique has been modified. Now let us see what actually this modification is, because when we were doing the original Schrodker procedure, we were doing lot of dissection anterior posterior to cervix, but in modification we restrict ourselves to the anterior aspect, and the sutures are buried. We don't see the knot here, no knot visible. Clear? And this is, we are talking about modified Schrodker. So knot is not visible here, and this actually minimizes the chances of infection. So this is modified Schrodker's procedure. So the main difference between the conventional Schrodker and the modified Schrodker, which are done for cervical incompetence, is actually the technique of suture placement, number one, and more importantly the extent of surgery, right? So suture placement and extent. In the conventional Schrodker, the one which we used to do previously and which was devised originally, here we have to operate the patient extensively, because here we need two incision, right? One in the front and another in the back. So one anterior and one posterior, and this is to place the suture at the level of the internal os, right? So I think you must be knowing what is internal os and what is external os. Anyway, so this is the conventional or you can say the original Schrodker procedure. Now there is some modification to this, and in modified Schrodker, what we do, one thing is that we have limited the extent of surgery or the dissection of the surgery. So here we have minimized dissection, right? So we are giving only incision, one incision, and that is only on the anterior part, no incision on the posterior part. So this way we have reduced the amount of surgery which is being done, and also the suture is placed closer to the internal os, and here the knots are not visible, right? So the suture is placed closer to the internal os, and this minimizes the risk of infection and also the complications which were associated with larger dissection as we used to do in the original technique of Schrodker procedure, right? So this one is the modified Schrodker procedure, where we are not visualizing the knots of the suture, right? So simple as that, okay? And we are just operating on the anterior aspect. Clear? So we are just operating on the anterior aspect and higher up towards the internal os. So it is Schrodker, and the knots are not visible, so you can say it is modified Schrodker. Okay, so again, this is a very tough question, and unless and until you have assisted somebody, it's little difficult to answer. But yes, the topic is very important, that is cervical incompetence. The topic is very important. The next question: after a delivery, mother developed abdominal pain, right? There is breathlessness, hypotension, tachycardia, and shock. So the mother, after delivery, she went into shock. Now, what is the clue here, or what is the catch here? That there is very less amount of bleeding. So bleeding is less, but the lady has went into the shock. And now in such a cases, less bleeding with shock, you should keep two possibilities in mind, right? So either there is amniotic fluid embolism. Clear? So either there is amniotic fluid embolism, or there is uterine inversion. Clear? So in this particular case, we can think of two possibilities till this period, till this line, right? Now the another statement is like there is a large bogey mass at the introitus, and this goes more in favor of uterine inversion. So this is a typical case of uterine inversion, which is a complication of mismanaged third stage of labor. Clear? And what do you mean by the word inversion? Like, if suppose this is the uterus, the placenta is like this. Now if you give traction over the placenta when it is still attached to the fundus, what will happen? The fundus will come out like this outside, and this is the placenta which is attached. So this is known as uterine inversion. The uterus has come outside because what you have done, you have pulled the placenta when it was still attached to the fundus of the uterus, and therefore it has brought the uterus inside through the introitus, outside through the introitus. So this is uterine inversion. Clear? And this is a classical case of mismanagement of the third stage of labor. And this is how you can see, this is all uterus. Okay, so this is all uterus here, and this is the placenta, and this is the umbilical cord, right? This is the umbilical cord, and this is the placenta which is still attached to the uterus. So if you give any traction, it is going to pull the uterus outside. So this is uterine inversion, and this can lead to shock. And yes, in this case you will not find any feature of bleeding. There is no bleeding. So you will be surprised that there is no bleeding, but how come the patient is going into shock? So this is the cause for that, uterine inversion. Now there is one more question, and here the placenta is invading into the urinary bladder, right? So this is urinary bladder. Now if you know the anatomy of the uterus, so suppose if this is the uterus, something like this, the urinary bladder is in front, something like this. Okay, so the urinary bladder is like this. So this is urinary bladder and this is uterus. Now normally what happens, the placenta is limited only to the endometrium. So suppose if this is the endometrium, the placenta should be here only. Okay, now we can understand the pathology of placenta. Okay, this will be placenta. Now we can understand the pathologies in terms of the extent of the placenta, right? So for that we need to know the layers of uterus. So the innermost is endometrium. Okay, so this is endometrium. Metrium is related to uterus. Then after endometrium, outside is myometrium. Myo means muscle, so myometrium. And the outermost is the serosa. Okay, so this one is serosa, the outermost covering. Okay, and anterior to this we will have the bladder. So here is the bladder wall. Clear? So this is the urinary bladder wall. Now normally the placenta should stay like this. This is the normal. Clear? Sometimes it can reach up to myometrium. This is accreta. Then it can invade myometrium, it becomes increta, and sometimes it can go through the muscle of the uterus till the urinary bladder, that is percreta, right? So accreta, increta, percreta, and you can take the initial word. So A for attachment to myometrium, I for invasion through the myometrium, and P for perforation through the myometrium. So all the terms you can discuss in relation to myometrium. Okay, so what is myometrium? Myo is muscle. Clear? Metrium is of course uterus. So if I just draw it in terms of say myometrium, suppose if this is the myometrium, okay, so take this as myometrium. If the placenta is coming like this, this is accreta. If the placenta is going like this, this is increta, invading, right? And if the placenta is going like this, this is percreta, perforating through the myometrium. Clear? So please remember this. And therefore in this question, since the placenta is perforating through the myometrium, reaching up to the urinary bladder in the front, the answer will be percreta. Clear? So here the answer will be percreta for this particular description. Clear? Next question. Now this is again a repeated question. It has been asked many number of times. Variable decelerations in fetal heart rate tracing. This is cord compression. Okay, so this is cord compression. That is umbilical cord compression. Okay, right? So variable is cord compression. And because what we see, like deceleration means there is a fall in fetal heart rate. So this is deceleration. Okay, this is small deceleration. This is deceleration. This is deceleration. The fetal heart rate is going down, and these are uterine contractions. Okay, so there is no relationship between the fetal deceleration and the uterine contraction, and therefore we call it variable. Okay, so there is no correlation between the uterine contraction and deceleration of the fetal heart rate, so we will call it variable deceleration. Please remember it for cord compression. The next question is about perineal tear, and here it is being said that there is less than 50% of the involvement of external anal sphincter. Okay, we know that there are two types of sphincter, external and internal. So external anal sphincter, if the involvement is less than 50% of its size, you will call it 3A, right? So this is 3A. And if the involvement is more than 50% of the size of external involvement, external anal sphincter, you will call it 3B. Okay, so this is 3A and 3B, which is related to the thickness of external anal sphincter, right? Less than 50%, grade 3A perineal tear. More than 50%, grade 3B perineal tear. Okay, so this is the question about perineal tear. Now, there was one maneuver which was shown, and it was asked like, what is the purpose of doing this maneuver? Now, this maneuver, again, this is a tough question because it is not much taught. So this maneuver is known as Rigiden Maneuver. Okay, so this is Rigiden Maneuver, and this is to prevent injury to the perineal structures, right? So this Rigiden Maneuver is a technique which is during, you can see this is there is elevation of chin and there is manipulation of the fetal head. So this is done when we want to minimize the chances of perineal tearing. So we just want to minimize the chances of perineal injuries. Okay, so this is Rigiden technique, and here what we are doing, we are applying pressure to the fetal chin. Okay, so we can see we are applying the pressure here to the fetal chin. Okay, and secondly, we are also applying pressure over the occiput. Okay, so here we are applying the pressure over the occiput. So chin, occiput pressure is given, and this is to guide the head's extension, and we want to make sure that the delivery of the head takes place in a controlled manner, minimizing the chances of injury to the perineal structures of the mother. So this is Rigiden maneuver. Now, which artery is monitored in fetal anemia? In case of fetal anemia, which artery is monitored? And this is middle cerebral artery. So this is middle cerebral artery, which is principally used for monitoring using Doppler ultrasound, and we actually check peak systolic velocity, PSV. So in Doppler ultrasound of middle cerebral artery, we check peak systolic velocity, right? So if there is increased middle cerebral artery peak systolic velocity, that is an indicator of fetal anemia. Why? Because the fetus compensate for reduced oxygen carrying capacity by increasing the fetal blood flow velocity, right? So if the velocity is more, it means there is anemia. So this is very important to remember. Clear? So for fetal anemia, we check the peak systolic velocity in the middle cerebral artery using Doppler ultrasound, and if we find that the velocity is more, it goes in favor of fetal anemia. Clear? So this is also one very important question. Now this is one more repeated question. Placement of the cup of vacuum. Now it depends whether the question is in relation to posterior fontanelle or whether the question is in relation to the anterior fontanelle, right? So suppose if this is posterior fontanelle, if you remember lambda, and anteriorly there is anterior fontanelle, which you call bregma, right? So if we are discussing in relation to posterior fontanelle, we have to go back 6 centimeter, and if we are talking in terms of posterior fontanelle, we have to come in front 3 centimeter. So 3 centimeter front of posterior fontanelle, or 6 centimeter behind anterior fontanelle. So please remember, the question is about which fontanelle, and then mark accordingly, right? So 3 centimeter in front of posterior fontanelle or 6 centimeter behind anterior fontanelle, you have to apply the cup of the vacuum, right? So this is known as the flexion point in vacuum, right? So please remember this. Then engaging diameter in phased presentation. In phased presentation, if you look here, the head is extended. It is fully extended, right? The head is fully extended, something like this, and therefore the diameter of engagement, as you can see with this pink line, this is submentobregmatic. Clear? Submento. Sub means, right? So the word sub means below. Mento means chin. Okay, so the word mento is chin. And bregmatic is actually bregma, or what you say anterior fontanelle. So this is bregma. So in case of phased presentation, right? So this is the phased presentation, right? This is a phased presentation, and the engaging diameter is submentobregmatic, and the fetus head is fully extended, right? So this is in case of phased presentation, submentobregmatic. Now, in a case, the shape of the abdomen was groove-like. Now, groove-like, what do you mean by the word groove-like? Like, there is one elevation like this, and then there is one more elevation like this. So, this area is known as groove, right? So, this is groove. So, here we can see this is one swelling, this is another swelling, and therefore, this area is converted into a groove. So, the shape of the abdomen is groove-like. Fetal body parts were not felt. Now what is this? Now this is because of a ring here, right? So there is formation of a ring, and this ring is formed because of obstructed labor, right? So what is the reason? There is obstructed labor, right? So this ring is because of obstructed labor, and therefore this ring is known as Bandal's ring, right? So Bandal's ring, which is also known as a pathological retraction ring, and this is a ring which is located at the junction of the thinned lower uterine segment, right? So thinned lower uterine segment and a thick retracted upper uterine segment. So at the junction of the two, and this is especially seen in cases of obstructed labor, right? So there is a ring at the junction of the thinned LUS, right? So you can say this is thinned lower uterine segment, and this is thick upper uterine segmented, and this is thick because it is retracted. Clear? So this part is the Bandal's ring, which is also known as the pathological retraction ring, and it's a feature of obstructed labor, right? So these are the questions which I could gather for obstetrics, and I'll try to take gynecology very shortly. So thank you everyone for joining me so late in the night. May God bless you. Good night. Bye bye.